Hello and welcome, or welcome back, to this third post in this series entitled ASD in Three Dimensions. My name is James Coplan, MD, and I will be your guide to this material. In this series, which is intended primarily for parents, but also for child care providers and community decision makers and interested parties of all kinds, we will cover the basics of what is autism spectrum disorder, what causes ASD, what can we expect in the future, and what can we do. Last week, I introduced you to the contributions of Langdon Down, MD, a British physician who lived in Victorian England and who provides the first contemporary description of what we now recognize as autism spectrum disorder. This week, we will discuss the person who is arguably the best known name in the autism field and the beginning point of the story in America for autism, O'Connor, MD. Last week, we left off with Langdon Down in Victorian England, and now, through the wonders of modern science, we leap ahead from 1887 to 1943. To O'Connor. Here we see Dr. Connor, who lived from 1894 to 1981. On the right, we see Johns Hopkins Hospital, where he practiced for the bulk of his professional career and where he earned his claim to fame. Here, on the left, we see yours truly, who trained at Johns Hopkins Hospital, and when I was in my fellowship at Hopkins, I had the pleasure of meeting Dr. Connor and hearing him speak as he reflected on the impact of his 1943 paper. O'Connor was born in 1894 in what was then, or what is now, part of the Ukraine, and what then was part of the Austro-Hungarian Empire. During World War I, he served in the Austro-Hungarian Army in the Medical Corps. In 1924, because of rampant hyperinflation across all of Europe, he emigrated to the United States, having taught himself English through the study and completion of New York Times crossword puzzles, which are hard enough for me, and I'm a native speaker of English. In 1928, he was awarded a fellowship at Johns Hopkins Hospital, and shortly thereafter, he was appointed head of the newly created Children's Psychiatry Service at the Harriet Lane Home, the Harriet Lane Home being the inpatient pediatric unit at Johns Hopkins. And in 1935, he published the first textbook of child psychiatry in English, Child Psychiatry. And then in 1943 comes this paper, which is really a landmark in the field of autism, published in a journal entitled The Nervous Child. And the article is entitled Autistic Disturbances of Affective Contact. And it begins as follows. Since 1938, there have come to our attention a number of children whose condition differs so markedly and uniquely from anything reported so far that each case merits, and I hope will eventually receive, a detailed consideration of its fascinating peculiarities. Now, you couldn't get language like that past a journal editor today. But let's unpack this sentence. And the first thing I want to draw to your attention is the two opening words, since 1938. Now, just park those in your memory, because we're going to come back to the year 1938 two or three times over the next couple of segments of this blog series. So just park that away. He says, there have come to our attention. Again, that's kind of a passive voice. He doesn't say, I have discovered. One almost wonders if he was saying, there have been brought to our attention, although he doesn't say that. Again, this is kind of a prequel to what we're going to be talking about in a couple of posts. So he goes on, a number of children whose condition differs so markedly and uniquely from anything reported so far? Well, no. In fact, we just got through talking about the fact that in 1887, or actually in 1885 or 1855 to 1858 or 59, when Langdon Down was the physician in chief at the Earlswood Asylum for Idiots in London, Langdon Down observed basically all of the things that Lee O'Connor is about to describe. That being said, Lee O'Connor still needs to get credit where it's due because his description is incredibly lucid. So let's look at what he actually wrote. And if you want to read the paper for yourself, and I think you should, especially if you have a child who's on the spectrum, or if you know somebody whose child is on the spectrum, and you really want to get a feeling in descriptive prose for what it's like, this is a wonderful paper to start with. And if you go to my website and you click on related links, you can actually get a copy of this paper. It's in the public domain, and read it for yourself. So he describes 11 children, 8 boys and 3 girls. And again, it's worth noting here that he publishes his paper in 1943, but the opening phrase says since 1938. So he's been following some of these children for as long as 5 years before publishing. So it wasn't as if he was about to rush into print with something. He took his time, he was very careful, and this initial description by Connor of spectrum disorder in some ways is actually also a longitudinal study throughout early childhood. So 8 boys, 3 girls, which is the typical male to female predominance that has stood the test of time. These children were aged 2 to 8 when they came to him, and he described symptoms in 4 areas: impaired socialization, idiosyncratic meaning very odd language, repetitious behaviors, and unusual responses to sensory stimuli. In terms of impaired socialization, he referred to his patients as quote-unquote aloof and quote-unquote withdrawn. And I put those words within quotes because aloof and withdrawn suggest a certain volitional or voluntary nature to the symptoms, as if the child might have chosen to be aloof or chosen to withdraw. But as Connor himself realized, and as we now know all too well, these are not behaviors of choice. These are part of the biology. He also described limited eye contact and a relative indifference to others, except when those others might serve as the means to an end of the child satisfying something, some need that he wanted fulfilled. The language idiosyncrasies included echolalia, which again Langdon Down described in 1887, speech being echo-like. Delayed echolalia, meaning a child might repeat something that they had heard hours or days before. It might just pop up in their conversation. I've had patients who memorize things like the weather report or baseball scores, and they start spouting these at the dinner table hours after they had overheard them, or segments from videos. Pronoun reversal. So the child might say, "You want a cookie?" rather than "I want a cookie." And this is actually just another form of echolalia, where the child is repeating verbatim what was said to him. If the parent says, "You want a cookie," the child then will say, "You want a cookie," as his signal, meaning "I would like a cookie." It's not so much pronoun reversal in the sense of confusing who I am with who you are. Rather, it's a robotic repetition of a code phrase. And then odd inflection. And it can sound kind of sing-songy like this, or very robotic like this, or any one of other disturbances of what's called prosody, prosody, which is kind of the melody or the inflection of speech. Then Connor described, as Langdon Down had, rigid routines. The mother has to park in a certain parking lot before walking into the mall, or the child will become distraught. One mother discovered she was holding her 9-month-old in her arms, and the mom was dusting the mantelpiece, and she had taken all the pictures off. And when she went and put them back, she didn't put them back in exactly the same arrangement they had been in before, and the child became frantic until she realized what was going on, and she replaced them as well as she could in exactly the same relationships to one another, and that relieved her child's anxiety. Stereotypies, this is just a fancy name for things like flapping and spinning and toe walking. It's just the term the British use, and we've adopted it in America. Things like lining up objects or spinning objects, or other kinds of fascination with things that give off repetitive sensory output. And again, we recall that Langdon Down talked about children flicking their fingers in front of their eyes. Connor described this as well. And this bridges over into the unusual sensory responses. A child might be petrified of the noise of the vacuum cleaner, and as I just got through saying, drawn to or fearful of spinning objects. Mouthing behavior, exploring things with the mouth, ingesting inedible materials. Incredible food selectivity, and we'll talk about this when we get to practical tips in behavior management. So these are the 4 areas that Connor described, and then uniquely, well, again, not quite uniquely, because Langdon Down talks about this a little bit, but Connor really goes into this in some depth. He describes over those 5 years that these children were under observation before he put it into print, a clear improvement in social skills, improvement in language, decrease in cognitive rigidity, that insistence on sameness, insistence on routines, and a diminution in the sensory aversions. And remember, there were no therapies. There was almost nothing. So these are really improvements that happened over time, irrespective of treatment. And Connor writes, and here we have some direct quotes, between the ages of 5 and 6 years, they gradually abandon echolalia and learn spontaneously to use personal pronouns. Language becomes more communicative, at first in the sense of a question and answer exercise, and then in the sense of greater spontaneity of sentence formation. Food is accepted without difficulty. Noises and motions are tolerated more than previously. The panic tantrums subside. The repetitiousness assumes the form of obsessive preoccupations, and we've seen this in teens and adults who may become obsessed with the internet or with computer hacking, or unfortunately sometimes they become obsessed with another person and may engage in behavior that could be construed as stalking or harassment when it's an expression of their obsession. Reading skill, Connor noted, is acquired quickly, but the children read monotonously, and a story or a moving picture is experienced in unrelated portions rather than in its coherent totality. And psychologists have subsequently coined the term central coherence, meaning the ability to see the big picture. And we'll get into this in another couple of posts, but I would like to demystify it right now. Here's an example of a first grade story that a child read to me. Muff. Muff is a little yellow kitten. She sleeps on a chair. She drinks milk. She does not like to get wet. So the child reads the story, reads it flawlessly, and then I say to the child, so, how would Muff feel if you gave her a bath? And the child says to me, I don't know. We haven't got to that part of the story yet. The child can't put himself into Muff's shoes, so to speak, and can't sense the big picture of the story. So he can't extrapolate from what he's read to the next step. And we're going to talk about many, many examples of that, and how children and adults, including the parents of children with autism, get into big trouble from their difficulty with central coherence. So Connor continues, between the ages of 6 and 8, the children begin to play in a group, still never with the other members of the group, but at least on the periphery alongside the group. And the underlining is in the original. And how poignant that is, and how observant that is, and how many parents have said this to me about their own child, who, when they go to the playground, now the child is always on the outer fringe, kind of running in parallel with the other kids, but never really interacting. People are now included in the child's world to the extent to which they satisfy his needs. And again, we've spoken about that, and we'll come back to that. Connor concludes, all of this makes the family feel that in spite of recognized quote-unquote difference from other children, there is progress and improvement. And indeed there is. But as Connor also notes, there is persisting difference. And the real question, and it's still a question on the table today, is how much improvement in any given child is because of the natural history of the condition for improvement over time, and how much of it is due to intervention. In other words, to what extent is a child more better? That's awkward English, but to what extent is a child more better because of intervention than they would have been because of the natural history of the condition? And this is another issue that we're going to come back to and talk about a great deal. Now, in 1971, 28 years after his initial paper, Connor tried to track down his original 11 subjects. So now we're talking about a 28-year follow-up, or plus another 5 years, almost a 33-year follow-up for some of them. Well, one was deceased, and 2 he couldn't trace. 5 were living in institutions, kind of a glorified warehouse situation. This was terrible. This continued to exist up until very recent times. And in some places, sadly, you can still find mega institutions where people are essentially confined. One adult was living on what in those days was called a work farm. It sounds like a very quaint term out of the late 1800s, but this was the case in the 1960s or 70s, a work farm. 2 were living at home. And if we drill down and look at those 2, one of those individuals was working as a machine operator in a sheltered workshop, but one of them had gone to college and earned a bachelor's degree and was working as a bank teller. So a tremendous, tremendous range of outcomes. And Connor also speculated in his 1943 paper, jumping back, to what might have been the cause for all of this. And he notes, it is not easy to evaluate, in other words, to know what to make of the fact that all of our patients have come of highly intelligent parents. Now, you've got to remember, Leo Connor was practicing at Johns Hopkins Hospital at the Harriet Lane Home Psychiatric Institute, the Phibbs Psychiatric Institute at Harriet Lane Home. There was a socioeconomic bias to the group of people who were able to fight their way up the food chain to get in to see him, so we don't know how representative his sample was. I don't think he had many children from the urban environment immediately around the hospital coming to see him. But taking it with that caveat, he writes, this much is certain, that there is a great deal of obsessiveness in the family background. The very detailed diaries and reports and the frequent remembrances after several years that the child had learned to recite 25 questions and answers of the Presbyterian Catechism, not 24, not 26, or to sing 37 nursery songs, or to discriminate between 18 symphonies, furnish a telling illustration of parental obsessiveness. And I have to say, I've had similar experiences with the parents of my patients, and their parent questionnaires were detailed in painful extreme, which really was reflective of their own traits as well as those of their child. And Connor continued, one other fact stands out prominently. In the whole group, there are very few really warm-hearted fathers and mothers. For the most part, the parents, grandparents, and collaterals, meaning aunts and uncles, etc., are persons strongly preoccupied with abstractions of a scientific, literary, or artistic nature and limited in genuine interest in people. Even some of the happiest marriages are rather cold and formal affairs. 3 of the marriages were dismal failures. The question arises whether or to what extent this fact has contributed to the condition of the children. And here we get a little inkling of what would flourish into the so-called refrigerator mother theory of the 1950s, which did untold harm by implying that refrigerator mothers had caused their child's autism. So O'Connor, in his original paper, flirts with this, and in the 1950s, he actually winds up for a period of time endorsing this, which is regrettable. But his original premise in his original paper continues as follows. Connor writes, "The child's aloneness from the beginning of life makes it difficult to attribute the whole picture exclusively to the type of early parental relations with our patient. We must then assume," and here's the key, "we must assume that these children have come into the world with innate inability to form the usual biologically provided affective contact with people, just as other children come into the world with innate physical or intellectual handicaps." And I am thinking of the mother of one of my patients who said to me after I had diagnosed her child at age 2.5 with autism, she said, when they handed him to me in the delivery room, I knew something was the matter. And she continued, "I breastfed my son for the first 9 months, and in those 9 months, he never looked up at me once." And a story like that is heartrending, to be sure, but it also speaks to the fact that from the very beginning, there's something quite clearly different about so many children on the autism spectrum. Now, there's a group of children who undergo some sort of stagnation and decline in the second or third year of life, and that's another story. But clearly, there are children who come into the world with this innate difficulty right from the beginning. And Connor continues, "If this assumption is correct, a further study of our children may help to furnish concrete criteria regarding the still diffuse notions about constitutional components of emotional reactivity." What he's saying there in plain English is, in 1943, they didn't have MRIs, they didn't have brain scanning technology to understand anything about the biology that underpins human emotion or human attachment. And we're just beginning with today's diagnostic and investigatory techniques to be able to understand some of those things. And Connor concludes, "For here we seem to have pure culture examples of inborn autistic disturbance of affective contact." And affect means emotion, and the italics are in the original, and he was exactly right. So when we sum up Connor's contributions, first, he gives us an incredibly rich description of the features of spectrum disorder in the 4 domains that have stood the test of time. I know they've been collapsed into 3 in the latest edition of the DSM, but that's another story. Connor talks about social, language, repetitive behavior, and sensory aversions and attractions. Second, in terms of attribution, just like taking any exam, he should have stuck with his first answer. In other words, this is an inborn disturbance of affective contact. And perhaps most importantly, he describes what I refer to as the natural history of autism spectrum disorder. In other words, this is a condition that looks a certain way at the beginning, and then it evolves according to its own principles. Pregnancy has a beginning, a middle, and an end. Measles has a beginning, a middle, and an end. Autism spectrum disorder evolves according to a highly predictable pattern, which we'll talk about in great detail. But the bottom line is that for at least some children, there's substantial improvement over time, irrespective of or regardless of treatment. Which leads to what I call my 3D model of spectrum disorder, and I'm just going to give you a sneak preview of that right here. We're going to come back to this in great detail down the road as well. I want you to imagine a plane, a piece of paper, a flat piece of paper, and we can draw an x-axis. Now, don't get math anxiety on me. This is just a horizontal line, and on the left we have severe, and then in the middle moderate, and the right mild. Atypicality. Atypicality means all those disturbances of language and social interaction and repetitive behavior and sensory processing. We just blenderize all of that, and we think of that as severe, moderate, or mild. That's an oversimplification for the sake of a model. I know that, but just stick with me. So we have a gradation of severity from severe to mild. And then we add to this a second dimension, which is IQ. And IQ can be in the average range, which 100 is the hypothetical average, or high average, superior, genius up here. And then we go down this way, we have low average, borderline, and down here is what used to be called mental retardation, but is now called intellectual disability. So you can have mild, moderate, or severe to profound intellectual disability, and we can have any combination of any degree of atypicality with any degree of IQ, from genius IQ to profound intellectual disability. And it's the combination of these two ingredients, the combination that has so much to say about the long-term outcome. So we're going to take this hypothetical piece of paper, this flat plane, and we're going to rotate it slightly. Okay, that's the same two axes. You've got atypicality running this way and IQ running that way. And now we're going to add a third axis, which is time. And now what we have, this is now a three-dimensional graph, sort of like a loaf of bread, where the first slice is that initial plane, and then slice by slice you go through the loaf of bread as you go forward in time. And at each point in time we can look at how the symptoms of spectrum disorder have evolved in a given individual as a function of where they started out back here. Now, this is just a tiny sneak preview. We're going to come back to this in several more posts, but I just wanted to slip this in. And in the very next post, we're going to come back to this sentence where Connor says, since 1938, and we're going to unpack that. And in the course of so doing, we're going to talk about Hans Asperger, whose name you already know, and then two other people whom you probably have not heard of at all. Well, that about wraps it up for today. Thanks for sticking with me. I know we covered a lot of material. I hope you'll be back next week. And let me just offer my apology for being a day late. I had a software upgrade this past week and it put me off by a day, but I hope to be back again a week from yesterday. Thanks, and until then.